think we're going to go ahead and get started, and as people call in, they can join in the discussion. But today's topic has to do with standardization of care, and we're talking more about evidence-based practice and some of the pitfalls and promises of it. Dr. Kevin McCabe is going to be our primary moderator. Again, I want to remind everybody, you feel free to mute, but please don't put us on hold. It really throws the conference for a loop. So, Dr. McCabe, it's all yours.
Thanks, Shiva. I'd like to start by just thanking Shiva for all the work and effort he's put into this journal club. He's basically set up everything that's enabled this to happen and has facilitated a lot of these presentations as well. The paper or article that I chose for this is called Promises and Pitfalls of Evidence-Based Medicine. And if you connect online there, I have an outline where I basically outline the whole paper. And I'm going to run through this quickly and then open it up for discussion in the end. The reason why I chose this topic is because as Banner gets into the ACO environment, there's going to be a lot more of a push to maximize effectiveness, efficiency, quality, containment, safety in the delivery of health care, and practice guidelines are one way of achieving that. But if you look in the literature, you'll find that, and I'm sure many of you have already experienced this, is that there are some problems with implementation of practice guidelines, even though it seems like the obvious thing to do. Going to the paper, the first part is just kind of introduction and background information about evidence-based medicine and clinical practice guidelines. Beginning with the definition of evidence-based medicine, is defined as the conscious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients. And as far as applications of evidence-based medicine, they've been variable over the years. The ones I have listed there, the first three apply to research. The fourth one is applies to critical self-evaluation, where you can try to figure out how you fit in the scheme compared to everybody else. The one we're going to discuss mostly today, though, is the fifth one, where it involves improving clinical experience with better evidence, and this has taken center stage in the last several years. Basically, this involves the use of practice guidelines or practical guidelines during clinical decision-making to encourage effective care. Some examples of the guidelines are given in item C there, including when to order diagnostic or screening tests, when to provide certain medical services, how medical services should be performed, and how long the patient should be hospitalized. Now, the purpose of evidence-based medicine is to provide a scientific foundation for clinical work to achieve these various goals that are listed here, including consistency, efficiency, effectiveness, quality, and safety. And some of these actually also facilitate other things, like, for instance, quality. It's been shown that if you develop a lot of quality in your system, sometimes the costs go down together with that. The next item, E, just lists some of the major issues that medicine is confronting. The third one is the one that we're going to be involved with here today. It's a major variation in accepted clinical practices, and that ties into the standardization of care. And so item F goes into that topic, major variation, and some of the concerns in the variation include overuse, underuse, and misuse. And the basis of these concerns comes from epidemiological research, which basically found that there's great variability depending on where patients receive care. Moving into the application of evidence-based medicine, this is basically the steps in creating and applying evidence-based medicine through clinical practice guidelines. And some of those steps include defining a focus and an audience, and then obtaining evidence and synthesizing it, and usually based on statistical analysis or controlled studies, but those aren't always available, and in fact they're frequently not available, so sometimes you have to deviate from that and just accept whatever's available. and then summarize the risks and benefits, and then determine the appropriateness of the intervention, to your patient population. Now, because of the big focus on evidence-based medicine and clinical practice guidelines, this has expanded almost exponentially in the last decade, and I've listed a bunch of different items reported in the paper of the proof that evidence-based medicine has taken center stage and is rapidly advancing. But then that's also led to some pitfalls. Some of these are listed in item H there, that are, a lot of it's due to the rapid expansion. And basically what's happened is it's created a lot of confusion, and there's a lot of overlapping, conflicting, and poorly constructed guidelines. And so some of them fail or appear not to work well, and then that turns some people off to that. And then, as I mentioned before, the gold standard of evidence, the meta-analysis of large double-blind randomized control studies is rarely available. And so hence, the researchers have to rely on other methods, and some of those are listed here below. And those are less desirable, but sometimes that's all that's available. Now, moving into the purpose and premise of the article, the purpose of the article was to review why evidence-based medicine has been attractive to many healthcare players, while others have had problems with it, had mixed feelings about it. And then another focus is using an example of one clinical condition, asthma, to assess the limited success of clinical practice guidelines in changing clinical behavior. And then the third is to highlight a promising approach to guideline implementation. And the premise that I have here in B is basically based on problems that were observed by reviewing the literature in the past and about the mixed records of the application of clinical practice guidelines. That's all kind of spelled out here, but basically the premise is that problems with compliance are due to physicians being the sole decision maker, and that plays into some of the conclusions in the end. Now, going back into evidence-based medicine, the paper discusses the polarization that has become evident over evidence-based medicine. You have both your supporters and your critics, and then I've listed a whole list of things under each category that apply to each. For the supporters, they often see it as a panacea for the problems of dealing with rising costs, inequity, and variability in care, delivery of care. And it enables physicians to draw on the objective experience of large studies or many studies, multiple studies, and to be able to apply that to their practice without having to do all that themselves. There's improved efficacy, sometimes will enable a hospital to divert scarce resources with proven effectiveness, to the front. It enables you to promote greater uniformity by limiting variance in procedures and limiting the rate at which some procedures are performed. It helps create better informed patients and clinicians. Sometimes it enables the clinicians to counter managerial decisions. It enables managed care companies sometimes to use CPGs as tools to implement cost-cutting measures, and sometimes it's used in the construction of public policy, as we're seeing being used by Medicare now. Some of the critics' positions include scientific problems of creating sound guidelines when the evidence is weak, and then there's the perception of destructive effects of standards at a local level in some cases. And then it also has the possibility of creating disincentives for individual innovations and healthy competition. And some will say it causes stagnation in the delivery of care. And another argument is that it may result in a lower standard of safety. Sometimes the practitioners, it's perceived, can become de-skilled as they treat all patients the same and basically do the same procedure the same way all the time and don't modify things when the clinical situation calls for it. And the other concern is that traditional healthcare professionals may be replaced by less skilled workers, and we have seen some of that occur. Now, the paper uses an analysis by sociology of professions. It's a sociological paper, basically. And the premise on the basis of sociology of professions is that professionals distinguish themselves from other occupations by special character of knowledge required to perform the tasks. And what matters most is the profession determines and evaluates the technical knowledge used in its own work. And then I've listed some other proponents and opponents positions with regard to that. In the next area, I'm going to skip through that part, though, because it's not as important for our discussion today. I'm going to jump down to item 5 and get into the part about the experience with the guidelines. This was the second purpose of the paper, is to use the studies to basically document some of the issues involved. Asthma was chosen as an ideal disease to study because it was a serious health concern. There have been many treatment protocols that have been developed and even revised in recent decades, and it became an early target for standardization via guidelines. And it's also among the best known of the pediatric clinical practice guidelines. And the results, basically the overall effect of asthma clinical practice guidelines was mixed and basically disappointing. Some of the problems that they found are listed under item B. Dissemination of the guidelines, they discovered when they did a survey 4 years after implementation that only 45.5% of the respondents had reported that they even heard of the guidelines. Another study reported 24% had heard of the guidelines. And during that period, they discovered that there was still a wide variation of the practice. Another major problem was acceptance. There was a national survey that showed that 88% of people were familiar with it, but only 35% followed the guidelines, indicating that many of them didn't accept the guidelines. And then there was a 1999 study that showed that after a hospital committee accepted the clinical practice guidelines and then went through the trouble of testing them for 6 months to get rid of all the bugs and to educate the staff, the adherence was still only 68%. And lack of adherence, which appeared to be one of the most significant problems, was found to be independent of the clinical setting, the severity of the disease, the hospital size, socioeconomic status, and the insurance or the who is paying for the care. So it appeared that none of those factors seemed to play into why this was occurring or why this was unsuccessful or had limited success, I guess I should say. There were other studies where they showed clinical practice guidelines in other clinical settings. There was a Netherlands study which showed 67% overall adherence in all of their practices to clinical practice guidelines. And then a summary of other research showed that the probability of adherence is only about 50%. So as far as the assessment of implementation outcomes, some of the barriers that were found to adherence include the items listed there under item A, and that includes lack of awareness, familiarity, agreement, self-efficacy, and lack of expectations about outcomes. Another major factor is inertia of previous practices, and that's something that we've seen here in trying to implement some things. And then there's other various external influences that also contributed. Now, the assumptions there would predict, I listed here below from the paper some assumptions that would predict that the clinical practice guidelines really should work, because both proponents and opponents both have a strong belief in the rational power of science, which this is all based on. And if best evidence is available, good clinicians would expect to automatically follow these recommendations. So what it came down to was they proposed the underlying basis of the disappointing outcomes is that a key characteristic of professionalism is autonomy and discretion in professional work. In other words, physicians as professionals should be able to, decide really what they think is best and act appropriately. And it been found that professionals seem to treat the guidelines more as options rather than as standards. Professional organizations do not enforce adherence to clinical practice guidelines or even reward guideline adherence or guideline following behavior. And compliance seems to depend on the best fit between the standards and goals and the demands of the individual healthcare providers. So the conclusions of these implementation studies also were that passive education strategies that are commonly used have very little effect in changing the behaviors, and one implementation model doesn't fit all. So this leads us to the third part of the study, which is the multifaceted approach to evidence-based medicine implementation strategy. There were two specific studies cited. One was the Royal Children's Hospital study in Australia. The other was a hospital pneumonia guidelines of EMS and the implementation in one hospital system. And just to put it all in a nutshell, basically what they showed was that the key, they were able to achieve a success rate of 95% in the children's hospital study, and they didn't say what the rate was in the pneumonia guidelines, but did say the compliance had greatly improved. And in both cases, the result was achieved by engaging basically all of the stakeholders involved, not just having the physicians decide what's the best way to go, but getting teams of nurses, other ancillary healthcare providers, even equipment distribution centers, and then involving media campaigns, getting parental involvement in the case of children, and getting patients involved even in their delivery of their care. And then not only educating people in the beginning, but maintaining an ongoing education process, and then coming back and giving people feedback of what the results are and where things stand and where problems are, and then also being willing to modify some of the standards as they see fit or as it becomes apparent needs to be done. One emphasis in this paper, or this article, was that these guidelines need to be evaluated at a local level and not just being used as a national type guideline that everybody would follow the same. They're doomed to fail in that setting because there are local variances. And so one thing that was emphasized is that everything should be done at a local level and with everybody involved. So item B here was basically the summary of that strategy, basically reaching out to multiple local stakeholders, the construction of a well-supported and uncomplicated guidelines with input from the various stakeholders. The implementation should be provided with strong leadership with sufficient resources, and that there should be a multi-stage education campaign, as I just pointed out. And at the end of this outline, I listed all the conclusions that are basically stuff that we already covered. So at this point, I'd like to open it up for any general discussion, and then I'll just throw out a few questions if anybody have any comments or?
Hey, Kevin, this is Nick Doshi. By the way, that was an excellent summary and presentation. I am really curious how other first world countries are managing this at a fifth of the cost. I agree this is a rampant issue within our...
I don't have that information. I mean, I haven't looked at all the data on that, but a lot of the other countries are facing the same problems that we are. You saw the report about the Netherlands study, which only had 67% of compliance across the board. So, this is a work in progress, and I think everybody's all reading the same stuff, but there hasn't been a lot of agreement on how to approach it. That's one of the reasons why I chose this topic, too, because there isn't any one good answer to everything. And I know that we're going to be dealing with this more and more as we go along, so the more input we have, I think the more strategies we'll be able to put together that are very effective. I do have some other papers that I'm going to post on the blog site that do have some reports of how some systems have handled this. So, one good one is from the Intermountain study up in Utah. And it sounds like they've gotten a pretty good handle on a lot of this stuff, and they utilize a lot of the strategy that we've talked about here, but then there's a few other things that they point out in their paper, too, that were very helpful.
Yeah, I think, I agree, Kevin. Excellent job. This is a dense paper to condense it down for people to understand was very nicely done. A lot of this has to do, in Brent James over at Intermountain Healthcare and what they've done, has to do with you have to have the technology platform to help study this. And you need to be recording and measuring and making transparent all the quality, initiatives and strategies that you have. And the other thing they've done is implemented the dyads, sort of, a physician and a nurse, physician and an administrator at each level. Much similar to what we have here at Banner, to help make sure that we have always a multidisciplinary discussion with regards to every guideline or every practice that we're trying to implement. The problem I have is this is all great, but it tends to stop there. I think the one step that still doesn't happen is at a local level. There has to be more multidisciplinary, all stakeholder discussion with regards to this. And that takes time, and that's going to take resources and money. But I think it's time, resources, money that we need to spend more up front to help make sure that these things are actually in place over time. Because if we just roll out these guidelines, roll out these practices, even though we think they're best practice, to get buy-in and to get compliance and adherence to guidelines, we're not going to get to that next step unless we get all the stakeholders on board up front rather than a rolling process.
And, we come from a culture where everything was done and everything was paid for. And now we're reversing the trend. And so that requires a lot of culture change and education. So,
yeah, and then one question is, how would you encourage adherence to clinical practice guidelines? That actually seems to be one of the major obstacles that we're dealing with. Well, for instance, would you leave it as optional? Some people would espouse and just hope for the best. Or would you use non-punitive inducements?
I think you need to have a discussion on the front end, and the other thing is, if these are well reviewed by the peers, the question is, what is our target? We need to have targets which are realistically achieved. Can we achieve 95%? That's good, but if you set up a target at 100. And that it's due to some patient issues or some other issues we are not going to achieve it, we need to be more realistic. What is our, how much can we do? 99%, that's good enough. I think that's a discussion we need to have at multiple levels. Again, as per the article, how good are the guidelines and what we can implement, take out of it and have that discussion and do the best, and how can we improve on it.
Well, I would agree with Ram, and this is Doug Cutler, that sometimes there's a law of diminishing returns. The difference between going from 95 to 100% may be cost prohibitive, but I can also use the example that with a lot of these guidelines, recommendations, sometimes it's how you implement it, how you're able to measure it, and how can we augment the use of technology to help. And I can use the example of the proton pump inhibitor initiative. We got as far as we could manually in educating physicians, and ultimately now we're having to go to an IT response where you're going to have to explain why you're ordering something before it gets done. because that's the only way we're going to be able to get that kind of education and behavior shift or change done.
Yeah, I think we absolutely have to leverage all the technology we have, the EMR systems and the alerts we have. The problems on the other end, and this is something that we've seen, for example, with sepsis and some of the other initiatives, where there's a tremendous amount of IT alert and bundles and things that everyone's aware of, but we still have 30-35% compliance across the system to something that we're trying to implement to reduce an enormous amount of lives, is that people rely solely on those alerts over a period of time. And they think that most physicians and providers will think, as long as I've acted upon it, my job is done. And that's part of the concern that I have with implementation, is that implementation shouldn't solely rely on those IT initiatives. And really, standardizing care should be, we're trying to standardize how we think, not how we care. So everybody think about this, and this is the minimum requirements, but then that doesn't mean you've done the job. And there's got to be more than just implementation of what's alerted or advised.
One of the things that, this is Carlos Alvarado, one of the things that I found quite powerful when we try to implement a new process, at least where I'm working, is to give feedback to the stakeholders or the people that are actually at the ground level implementing the changes. When we go back and tell them, this is where we were before we made these changes, and this is where we are today. And I think that that creates a feeling of pride and accomplishment when they see that the results are positive.
Good point.
Yeah, I think that's a good point. The question comes up, what do you do when you're faced with a clinician who says, well, this is the way I've always done it. It's not part of the guidelines, but my patients have always done well. What do you do in that situation?
This is Joe Lozon from Thunderbird. And I did have a conversation with one of our clinicians regarding the use of order sets. And the conversation went somewhere along the lines of, why am I going to use an order set to go and be told how to practice medicine when I've been practicing medicine for 12, 13, 14 years, and I think I've been practicing pretty good medicine. And I made 2 points to him which I thought were helpful. Number one, in this particular conversation, I stressed to him that order sets need to be employed after the clinical judgment of a physician at the bedside decides to apply a particular order set to a particular condition. So in other words, you have to assess the patient and make the right assessment. I mean, that's the upfront piece. But the other piece of this was, and it was regarding the pediatric DKA order set, I kind of posed the question to him that this pediatric DKA order set was designed by specialists, pediatric endocrinologists, who debated, thought about, went to the literature, and came up with what they thought was the best orders that could be applied to that subset of patients. And posed to him the question, if it was your child in a Banner ED, would you want the clinician to, so to speak, fly by their experience, which may be pretty good, or would you also want them to access the order set and that expertise in caring for a family member that may have that particular problem? And it neutralized his objections. He understood it from that perspective, and I don't think that's something that when the order sets first came out, that we didn't have a lot of evidence base and discussion about them, but they really have evolved over the past couple years, and there's a lot of expertise embedded within those order sets. So, that was one conversation that I thought that was pretty interesting.
In a situation like that, do you think it would have been difficult to engage that clinician to get involved in a discussion about, what works the best, or, his practice versus others?
I think it wasn't a versus type conversation. I think it was more of bring it on as a tool to go to and utilize to help you bring the highest level of care that you can to that patient. So one doesn't replace the other. It's more, I definitely use the orostats a lot. I think of it more of more than an adjunctive tool, but that's kind of the scripting I used in that conversation. And the understanding is there as an adjunct and not there to replace.
Yeah.
I think that helps.
We may have discussed this, but I'm curious, what's the biggest hesitancy in using standardized practice or following a standardized structure within Banner, for example?
I mean, you can look at some of the stuff that is even in this article. I mean, getting told
autonomy, art.
I think one of the largest components still is lack of awareness. I mean, we have hundreds and hundreds of practices that exist that come out the CPG or CCGs, and really still physicians are not aware of what they are and what they entail, and lack of awareness is probably still one of the largest ones.
I think lack of awareness was definitely, and then lack of feedback, as somebody earlier mentioned, giving them the feedback, look, this protocol has helped these patients, they're doing fine, and it works, like our sepsis bundle. It works. We've shown decreased mortality. So we need to collate and collect some data and give it back and feed it back into the system and share it with the stakeholders.
Any other thoughts on that?
I agree. I think it is educational, and I do think people need to hear that quite often the very people sitting in the room with them participated on those committees that collected the evidence and came up with those protocols. So they really are driven by their own colleagues, although they're system teams, it's their colleagues that are them on the system team.
I think this should be part of an onboarding process. Why do we do it, and how do we do the evidence-based medicine? I think because as physicians come on board, we are all trained in different situations, and everybody, even two training programs, I'll just say nephrology, if you train on the East Coast and the West Coast, there are different, how you train and how you come up with. But I think in the end, when it's very crucial to onboarding the physician, anybody new, is why do we use evidence-based medicine to get them on the right footing on the front end? And then whosoever is here, we need to keep on giving this message out why we are doing it. I think that's our biggest hurdle on the front end,
Yeah, I think that's a good point, and I think that's one of the things that the paper or article did emphasize was the continuation of the education and the continuation of the feedback. It has to be an ongoing process, and it probably requires a whole change in the way we think about doing things. It does require a lot more effort on a lot of people's part. And includes a lot of people outside the physicians, too. It's just not the physician's interpretation of how this patient is doing, but there's other factors involved as well, and, comparisons between his patients and those of other people who might be doing things differently.
Yeah, one of the things that Intermountain Healthcare, again, is successful in doing is they've also aligned their incentives to that of standardized guidelines, standardized practices, and that coming to the health system first in terms of ACO and healthcare reform, how our incentives as a system are going to be more aligned to these quality initiatives. Downstream to the providers, if incentives are better aligned to adherence and to highest quality care that's being provided, that provides maximum value to our patients, if that's done, that adds a second reason or way to motivate individuals to adhere to guidelines. That's more sort of, it's not punitive, rather it promotes those that follow them.
This is Ted Norman at McKee. I think when we're talking about guidelines, we have two areas that we care for patients. One is the hospital setting, which is really IT-driven now, and there's a lot of pop-ups and warnings and reminders, so it's pretty easy to restrict use of some interventions if they're not clinically appropriate. The outpatient setting is a little more difficult, and historically even some of these guideline committees have been fraught with some bias. They're very gray. They're suggestions instead of guidelines, and we focus more on the outpatient setting on preventative maintenance, ticklers, pop-ups, things like that, where we're going to get a lot more bang for our buck. The biggest resistance I see to guidelines in the outpatient setting is the guidelines are still, there aren't a whole lot of them. And we need to get the ones that actually are out there and develop in some case management, pharmacy clinics, hypertension management, A1C checking, those type of things in the guidelines so that we can probably provide better care. So I think there's two different approaches based on whether you're in an inpatient setting or an outpatient setting.
Excellent point.
That's a good point. And I'd like to go back to one of Nick's comments, too, which I thought was really good, and that was about the communication aspect of things. I think communication is where we really fall short in a lot of areas. I've experienced that myself with some of the clinical CCGs and some of the things that have come out of the CCGs that I was actually surprised to find out about, sometime after it had come out, and it wasn't until, we had experienced some problems that it became evident that there was already CCG guidelines established for certain things, and then on the other side of the coin, because things weren't communicated really well out to everyone, there was one particular guideline that we discovered that was out of date almost at the time that it came out, just because the testing that was required for it no longer existed or was no longer going to exist. So I think there is a communication effort that needs to be made with all of this. It's one thing to come up with the guidelines, but another thing to, get everybody to understand what they are and how to implement them.
I think as a healthcare system, we first need to identify within each specialty what the importance is, what resources are being used the most, and prioritize our task and what are we trying to target. Are we just blindly wanting everybody to follow these guidelines, which are ever-changing at times, but there are some that are very solid and have stood the test of time. So, and that's a tremendous amount of tasks. And the CCGs, there are hundreds of them, and I still don't remember using many where I can click on something and follow an algorithm based on what the CCG recommended. So that would require part of that awareness where to find the CCG, what those guidelines are, where their care, if there is a care set for that exists. And so I think communication, education, figuring out exactly what are we targeting? What do we want to reduce?
Any other comments?
I think on the other IT side, I think we have to rely on it, but I think I was just reading one of the studies recently is that the number of pop-ups, actually there's a certain amount of pop-ups beyond which it leads to more errors because of less critical thinking, because the important tasks get put on the back burner. You are just putting out those pop-ups, or the alerts, discern alerts. So I think we have to be careful how many of those alerts we want to control the care with,
That's a good point, Robin. The one thing you get is desensitized to those alerts. And the one that I've actually found helpful was something I recently did. I ordered a stool study, and it immediately asked a set of questions that kind of narrowed the amount of work I needed to be done on the stool study. And I think ultimately alerts like that are going to be more helpful rather than where you choose and say not applicable or physician aware and just move on.
That's also, I think, important to communicate that, and as was pointed out earlier, people are not bound to those algorithms either. They're there to get around them requires a lot more effort and some justification, but you can still do it if you need to. Physicians still do need to think and not allow themselves to fall into the trap of the deprofessionalization, that was pointed out in the paper as one of the concerns to the opponents.
I think as a group of physician leaders, we all need to have this conversation with whoever it is that we work with, and not just physicians, but the groups of non-physicians that we work with, so that we do share at least listen to the concerns of those that don't want to follow these guidelines and find those barriers. Because as you identified earlier, for a lot of different people, it may be a lot of different issues. There may be some that are just not aware, that once they're aware, we'll start following them, and all of a sudden your adherence might double, and it didn't take anything but a conversation with a larger group. It's a conversation that, as Raman pointed out, maybe should occur at orientation, maybe should occur at staff meetings, maybe should occur on a person, one-on-one basis. But it's a conversation that needs to happen at every facility within each department, and it needs to happen more rampantly now than before, because the rate of guidelines is increasing. I mean, the amount of information coming at us is enormous. So we at least have to agree on something. We have to agree that we're going to be looking at them and consider them. And ignorance is not going to be much of an option.
I think with the Banner Health Network and also the Banner Medical Group, what they're trying to now do is build divisions. I think that will be important for each division to identify what resources are being used the highest within their area and what they could do on their part to reduce it. And if that is something that requires simple implementation of a few guidelines, and that's the route we take. And as Shiva pointed out, we need to figure out what those barriers are for each of those specialties and identify those. And communication is always a key. So.
And are there plans to communicate that information out to the people that are not part of the Banner Medical Group and yet practice in the Banner system?
Ted, over in McKee, what would be a way that would happen to groups of physicians? Because I think there's quite a bit of private practitioners in Colorado, right, that are part of the.
Well, there's a couple of our, there's actually, we've got 150, 200 providers in northern Colorado that are part of Banner Medical Group. So the bulk of Greeley is Banner Medical Group, and in Loveland, really, it's getting narrowed down pretty quickly. The only big group left is an orthopedic group, and even some of their members sometimes participate on our own CCGs. So it's getting pretty tightly controlled. There's basically, you're either with a Food or Health System or you're with Banner Medical Group at this point.
Okay. Well, I'll say within the Banner Medical Group, what would be a way to disseminate some of the things that you talked about, with regards to, let's say, hemoglobin A1C, smoking cessation talks, and whatever it is that you need to implement as a standardized guideline. I mean, again, I don't think it's very effective yet. There's a lot of work yet to be done. What would be a good way that we can help that process?
So there's two ways to do it in my mind. Number one is to have more and more pop-ups keep occurring when patients show up in the doctor's office, and that's not helpful. The other does involve the development of our own case management program that can scrub and identify patients that fall in clinical criteria and manage to get them in for their selected appointments, tests, whatever, without getting the physician involved. It happens on autopilot. We're learning a lot about that with our affiliation with Kaiser, because that's how they manage most of it. When the patient's got an intake, they talk with an intake specialist that arranges all their routine healthcare needs and their follow-up stuff. They also manage very tightly some of the guidelines. So let's take PSA screening. Kaiser actually doesn't offer PSA screening in their own organization because of evidence-based guidelines. They just spread that across their whole medical group and said, we're just not going to do it anymore. So they have their own, they actually have a centralized research group within Kaiser in California somewhere that helps make some of their guideline decisions for them. I think we could learn a fair bit about that, but I think getting a case management and some sort of active management of these patients outside of their clinic visit is the only way you're going to do it. Most of us have probably seen the studies that show that it would take 7 hours of your day just to do preventative maintenance on patients, and that's not even taking care of their acute problems.
Well, I think that centralizing it makes sense because it takes that responsibility away, but I think it pushes accountability in the other direction, and getting buy-in from providers when such tasks are centralized is a problem. And I think to get to true adherence, you have to involve all of these providers in some conversation, and something needs to happen locally.
I guess I'm less optimistic about the motives of some of the doctors, because I think if they accept the guidelines but someone else will take care of the dirty work, they're more than happy to support it. But if it's a guideline that impacts the amount of work that they have to do in a given day, that just generates, illogical resistance. So I think when you tell them, hey, this is our guideline, we're going to take care of these things, in some way, and your patients are going to get some of this stuff done, so be aware of it, I think they're much more likely to go along with it than if you say, we're going to tag you with making sure that every diabetic is on an ACE inhibitor.
Okay.
Well, then that begs the question in the hospital setting of, how far do you go if somebody refuses to follow the guidelines?
A doctor or a patient?
A physician.
A physician. I'm on the pharmacy CG, so we control the pharmacy. So there are some drugs that you can't order. There are now some tests that you can't order. Blood work you can't order. You can't order Aranest in certain circumstances. I imagine at some point we're going to have pop-ups for blood transfusions. If our goal is to make every doctor 100% compliant, as someone else said, you're never going to get there. If your goal is to continually improve from where you are, then all these steps make sense. And I would worry more about the 10 doctors that follow the guidelines than necessarily the one doctor who's being obstinate about it, because I'm going to get, I've got my salvageables, your sinners, and your saints. And you don't have to worry about your saints. Your sinners, you might not change their mind, but you want to focus on your salvageables so that you can move the dial.
So you're basically saying you don't think the peer review process is the way to go to send everybody to peer review who's deviating?
Well, I'm also on our peer review committee, and I know that's been coming up. I think it's a dangerous precedent to use a clinical guideline as peer review, because you're starting to meld the medical legal world of medicine with the gray area of clinical medicine. I think there are some that are pretty standard. So let's say, you did something that, you forget to do a surgical procedure that was quite clearly indicated. That's part of our guideline. That's fine. You can probably task them with it. But if I was an hour late in reporting, or if I was an hour late in responding to a sepsis alert, is that a peer review issue? I think there's still got to be some level of distinction.
Yeah, that's a good point. That has come up in our medical executive committee, and that very question has come up. Do we push it to peer review? And I like your comment there. I think it's a good analysis.
I think peer review is good, but I think as any good thing, we overload it. Are we using it appropriately? I think that's the discussion. The other thing is on the hospital side, especially in the hospitalist world, I think where we are going as paramedical group is trying to screen and setting up expectations on the front end rather than have these conversations on the back end, And when you have the outliers, you can have a conversation not in a peer review, but on a different platform,
Getting back to my brief comment, in case people haven't heard this concept before, it's a political concept in that there are three groups of people you're trying to influence. The ones that are with you are the saints. They're going to help you no matter what. The ones that are against you are the sinners. Those are the ones that are going to fight you every step of the way. But the large group are called the salvageables. They're just looking for a way to go and way direction. Those are where you get the most bang for your buck when you focus your interventions.
Yeah, I like that analogy.
So don't work with anybody in Vegas. Yeah.
Any more comments?
No. This was great.
Yeah. Well, it's a great conversation. I'd like to thank everybody for their participation in this. One thing, Shiva put together this blog that we have for this ALP Journal Club, and I'm going to try to post some of this stuff on that. If anybody has any continued information that they want to post on there. We're also going to put a couple more articles on there of experiences of other organizations, in particular the Intermountain Group, which has pretty much gone a long way with this concept and have basically defined some processes that they claim works. And so I'd like to throw them out, and we'd appreciate any comments that anybody else would want to throw on about any of this stuff if you have the time to do it. Because I think ultimately, there's other people in Banner that can benefit from this information. I think this conversation is going to come up over and over again in various medical executive committees and everything. So I think we could all benefit from that.
Excellent.
Kevin, this is Sandy. If I can also just take a moment to say thank you very much, both you and Shiva. This is an exciting opportunity to establish the graduate program, the 5 tracks. Thanks to both of you for leading this, and also a little plug for May 22nd. The first annual retreat coming up, an invitation for all folks in Cohort 1 and Cohort 2 to continue building this kind of knowledge and community.
Thank you.
Thanks, Sandy. Thank you, everyone.
Bye.
Thank you, everybody.
The chairperson has left the conference. The conference will end in 1 minute.